Namaskar, very good evening, and a warm welcome to all the respected participants. My name is Ashish Tukal, representing G Healthcare Cardiovascular Ultrasound segment. Today, we are going to conduct an exclusive clinical lecture on diastolic dysfunction determination on our XP Connect webinar education series powered by Vivid Cardiovascular Ultrasound Technology from GE Healthcare. Heart disease is a leading individual cause of disease burden in India and globe. Diastolic dysfunction can be indeterminate and at times, and this requires a more comprehensive view of cardiac patient across the continuum of care. For the same, today we have with us one of the renowned name in the field of cardiology, Dr. Vatchsala Sree from Mehul Heart Center, Vellore. I welcome you, ma'am. Dr. Vatchsala is a well-known name in the cardiology community and has been contributing immensely. Before we get started, due to nationwide lockdown, there has been a huge traffic load on internet services. If you experience a temporary interruption in the transmission, kindly bear with us. We'll sort it out immediately and resume. I now welcome the esteemed faculty, Dr. Vatchsala, to address our viewers with her clinical talk on echocardiographic assessment of diastolic dysfunction determination. Over to you, ma'am.
Thank you, Ashish. Good evening to one and all. At the outset, I would like to thank GE for this wonderful, privileged opportunity and the opportunity to meet you all through this web series. And my prayers and congratulations for all the doctors who have been undergoing difficult times, particularly for the last 6 months with this COVID. And I know how difficult or how motivated you guys should be to participate in this webinar today. That tells me your keenness and your interest to learn about the diastolic dysfunction. And I hope that I'll do a great justification for your time. So moving on to the topic straight away. Today we're going to discuss one of the most important and most difficult topic in echocardiography, which is diastolic dysfunction. The reason why I myself chose this topic is because some of my colleagues said that it is a complicated topic, and I'm aiming to make it very simple for you today. Now, any diastolic talk is not complete without this slide. We must have gone through this slide n number of times, but still I would like to start with the same basic principle. So what is diastolic dysfunction? We all know that diastole is the filling phase of the LV. The most important crucial statement is, the most effective your diastole is, the more effective your systole is. So the effectiveness of your systole is determined by the effectiveness of your diastole. Hence, diastolic dysfunction directly or indirectly means systolic dysfunction. So what happens during the diastole? The LV, normal LV, the normal left ventricle, is a very stretchable, very compliant, very relaxable muscular organ. It can actually accommodate whatever blood is entering into the LV through the LA. So that happens in 4 phases. We know that just before the mitral valve opens for the filling, there is a very short time called as the isovolumetric relaxation time. The isovolumetric relaxation time is the period during which the mitral valve and the aortic valve is closed and the LV is allowed to relax. A kind of suction is created inside the LV cavity. This is the first phase. As soon as the mitral valve opens, the blood actually gushes or flows into the LV, and that is a passive process. And it is made possible because of the pressure created, the suctioning pressure created inside the LV because of the isovolumetric relaxation time. And also, when the LV, as I mentioned earlier, when the LV is stretchable, when the LV is compliant, when the LV is relaxable, no matter how much blood enters into the LV can expand. And then there is a third phase called as diastasis, where no filling happens. Whatever blood has entered into the LV just stays there. And the fourth phase is the final phase, where whatever blood is left in the left atrium is being pushed into the LV through the left atrial contraction. So this wave here, the E wave and the A wave. So before the start of this E wave, just imagine there is an isovolumetric relaxation time, very brief time. And the moment the mitral valve opens, the blood flows into the LV that is determined by the E wave. And then there is a small time gap between, this is the diastasis space where there is no filling happening. And then whatever blood is left in the left atrium is actually pumped into the LV by the atrial contraction that is demonstrated by the A wave. So this is what is the normal happen. Now what happens in diastolic dysfunction? Well, here I have actually put a slide where I have graded the diastolic dysfunction into grade 1, grade 2, grade 3. Some of you at this stage might have some confusion that actually there are 4 grades in diastolic dysfunction, but we'll come to that in the next slide. We'll clarify that in the next slide. For the time being, I'm just going to stick on to this grade 1, grade 2, and grade 3. So what happens is grade 1 is the very normal preliminary stage. It doesn't mean that the disease, coronary artery disease or something more serious has happened, but simply the ventricle has lost its compliance. The ventricle has become stiff. The ventricle is not able to expand more. It has become stiff. So what happens is the initial filling phase, which was actually very passive and very effective initially, is not that effective in grade 1 diastolic dysfunction simply because the LV is not able to expand. Okay. So because less amount of blood goes into the LV, more amount of blood stays into the left atrium has to now contract more effectively than normal to actually pump the blood or push the blood into the LV cavity. Therefore, in grade 1 diastolic dysfunction, you have a small E wave and a bigger A wave. So for us, what it means is less amount of blood is entering into the LV in this stage and more amount of blood is entering into the LV because of the atrial contraction. So this is grade 1 diastolic dysfunction. As I mentioned earlier, it doesn't mean that the left ventricular end diastolic pressure is increased or whatever. It is simply because the LV has become less compliant or it has become more stiff. Then you have grade 2 and grade 3. So what happens in grade 2 and grade 3 is, because of some disease process, be it coronary artery disease or hypertrophic cardiomyopathy or restrictive cardiomyopathy or whatever, valvular heart disease, the left ventricular end diastolic pressure now has increased. So the left atrial contraction or the blood that is going into the LV because of the left atrial contraction is less, because the left atrium is not able to create so much of pressure, so much of contraction against the elevated left ventricular end diastolic pressure. So basically the A wave and the A wave becomes smaller and smaller because of the increased left ventricular end diastolic pressure. The left atrium contraction is not effective against the elevated. So, because the A wave becomes smaller and smaller, whatever filling happening into the LV is only the first phase filling that was happening before because of the opening of the mitral valve. So, the E wave becomes taller and taller. The E wave is tall and the E wave is even more tall. The reason why here I say about the atrial contraction first is, because the A wave is small and the E wave is tall doesn't mean that more amount of blood is going into the LV than the normal. It's not like that. Whether it can be even little bit of blood going, but that is more than contributed by the atrial contraction and hence the difference in the EA velocity. Okay. So in grade 1, you have a E wave which is shorter than normal, whereas in grade 2 and grade 3, you have an E wave which can be equal or taller than normal. In grade 1, you have an A wave that is taller than the normal, whereas in grade 2 and grade 3, you have an A wave that is shorter than normal. And similarly, it is represented by the tissue wave Doppler. We'll come to this when we discuss about the tissue wave Doppler. Now, I just want to touch upon this two important guidelines. One is the 2009 Asc Guidelines and the 2016 Asc Guidelines. The reason why I thought it was important to include this in the topic is, of course, the parameters that we used to take into consideration for assessment of diastolic dysfunction has been narrowed down to 4 in the 2016 guidelines as opposed to 10 parameters in 2009 guidelines. We all know that when, round about in 2010 and 12, all people who have written the IAE exams, echocardiogram exams, the M mode, color wave propagation index and pulmonary wave Doppler and mitral DCT and mitral A wave duration, all these parameters we kind of kept on confusing, and we couldn't fit into those kind of parameters. So the 2016 guidelines aimed to simplify the 2009 guidelines and took into consideration only the most relevant parameters that has been proven to be important in not only in making an assessment about the diastolic dysfunction, but also in prognostication of diastolic dysfunction. So as I mentioned, the parameters that has been left is the pulmonary vein Doppler assessment, the Raymore color wave propagation index assessment, and the mitral DCT and mitral A wave duration. The 4 parameters that has been included and that we'll be seeing all the way through are the septal E by E dash average, the mitral E by E dash average, the LA volume, the TR velocity, and the septal E dash value and the lateral E dash value as assessed by the tissue wave Doppler. Again, in the previous slide I said, you'll be having confusion about the grades 3 grade versus 4 grade. So in 2009, the guidelines, we had 4 grades of diastolic dysfunction. One is grade 1, other one was grade 2, which was pseudo normalization, and then grade 3, which is increased left ventricular diastolic end diastolic pressure, which is reversible, and grade 4, which is irreversible. Now, how did we differentiate grade 1 and grade 2 is by the Vatchsala maneuver, and how did we differentiate the reversible and irreversible is again by the Vatchsala maneuver. But honestly, many of you would agree with me that we never did that in our routine clinical practice, and we had our own shortcuts way of saying this is grade 1 and grade 2 and this is pseudo and this is reversible and this is irreversible. But the 2016 guidelines actually took it away, the Vatchsala maneuver. And now we are left with only 3 grades, which is grade 1, grade 2 and grade 3. So there is no pseudo normalization and there is no reversible and irreversible. And how do we actually grade this? We will be seeing in the subsequent slides. Now, both the guidelines for that matter, the 2009 and the 2016, aim to tune us or train us to an algorithmic approach of diastolic dysfunction. So they want us to follow certain set algorithms. So the first thing that we have to identify is which algorithm to choose. Do I choose this algorithm? Do I choose this algorithm or this algorithm? So the one single factor at the very beginning itself that determines or that helps you to choose the algorithm is whether the LV systolic function as assessed by the ejection fraction is normal or depressed, whether the left ventricular size as assessed by the left ventricular hypertrophy size, is it normal or more. So in the 2D or with the initial assessment, you have to now decide whether we are dealing with the patient with reduced ejection fraction or normal ejection fraction, or you're dealing with a patient with left ventricular hypertrophy or normal LV. So the first step in the diastolic assessment is this. The moment you know you're dealing with a diastolic, you're dealing with a patient with normal ejection fraction, you have a different algorithm. The moment you're dealing with a patient with reduced ejection fraction or left ventricular hypertrophy, you have a different algorithm. And there are other special circumstances like what do we do in atrial fibrillation, what we do in mitral stenosis, what we do in mitral valve replacement, all those things, which we will touch at the end. So now, as I mentioned earlier, the 4 parameters that has been taken into consideration is the average E by E dash. So what we mean by the average E by E dash? So there is a capital E and there is a small e dash. So the capital E denotes the mitral inflow assessed by the pulse wave Doppler. The E dash actually denotes the velocity. The E dash actually denotes the velocity at the septum and the lateral wall as assessed by your pulsed wave tissue Doppler. Okay. And what is that average is, they actually take an average of the septal E dash and the lateral E dash, and then they find the ratio to the mitral E. Okay. And actually know these numbers. These numbers are very important. So those know the numbers. So the normal should be less than 14. If it is more than 14, it is abnormal. Again, we have the septal or the lateral E dash as assessed by the tissue wave Doppler at the mitral septal annulus or the lateral annulus, and any value less than 7 or any value less than 10 is abnormal. Normally, the mitral septal E dash at the assessed at the annular level will be more than 8 or the lateral will be more than 12. Anything less than 7 or anything less than 10 is abnormal. Okay. The third parameter is the TR velocity. So any TR velocity more than 2.8 meter per second or a gradient of 34 or 35 millimeters of mercury is abnormal. And the fourth one is the LA volume index. We will come to this in the subsequent slides, but at the moment I just want you to know about the 4 parameters and the normal values. So the 4 parameters are average E by E dash, septal or lateral E dash, TR velocity and LA volume index, and the numbers are more than 14, 7 and 10, 2.8 and 34. And this applies to when we are assessing the diastolic function when the EF is normal. So once we have all the 4 parameters, then how do we determine whether somebody is having diastolic dysfunction or not? So that is determined by the how many parameters are present. So out of this 4, someone is having 3 to 4 parameters positive, like their average E by E dash is more than 14, TR velocity is more than 2.8 or LO volume index is more than 34, then for sure they're having diastolic dysfunction. If only 2 is positive, either 2 is positive, then there is an intermediate one. And if only 1 is positive or none is positive, then they don't have diastolic dysfunction. So actually at this point in time, I would like to stress that when we are actually making a diagnosis of diastolic dysfunction in someone with preserved ejection fraction, it is actually very cumbersome. If you apply these 4 rules to an individual whose EF is normal, not many actually qualify for diastolic dysfunction, and they have to have at least 3 to 4 parameters positive to brand them as diastolic dysfunction. Now, once we have established that somebody has got diastolic dysfunction assessed by these 4 criteria, the next step is to grade them into grade 1, grade 2 and grade 3. Now, for grading, we need the parameters. That is the good old parameters that we've been used to, which is the EA ratio and the DCT. So again, the numbers are, if the EA ratio is less than 0.8 and the DCT is more than 200, it is grade 1. If the EA ratio is more than 2 and the DCT is less than 116, it is grade 3. Any value in between is grade 2. Okay, so we are all familiar with this. EA ratio less than 0.8 and DCT more than 200. EA ratio more than 2 and DCT less than 160. And anything between that is grade 2. Okay. Now the next algorithm is somebody with a diastolic dysfunction. You want to assess the diastolic function in someone with depressed left ventricular ejection fraction or with LVH. Okay. Or with the preserved ejection fraction, but who has been having these criteria, that is average E by E dash, TR velocity and LAVI, they are the numbers. If it is a bit confusing at this moment, just bear with me. We're going to see a lot of cases at the end where we are going to apply these algorithms and these numbers. Then the interpretation will become easy. Okay. So once you have a patient with the depressed left ventricular ejection fraction or LVH, then the first thing we want to know is the EA velocity and the E wave, the EA ratio and the E velocity. Okay, so see how the algorithm is changing. Now, when the LV function is normal, we directly wanted to go into these parameters. Whereas, when the LV function is abnormal or when there is an LVH, the first thing you want to know is what is the EA ratio and what is the E velocity. Okay. So if the EA ratio is less than 0.8, I'm sure you all know how the EA ratio can be less than 0.8. See, we established that in a normal individual, the E wave is taller and the A wave is shorter. So whenever the E wave is taller and the A wave is shorter, the ratio, the denomination, when you divide those 2 numbers, it should be more than 1, isn't it? So normally the EA ratio is more than 1.5. But in grade 1 diastolic dysfunction, we established that the E wave is small and the A wave is tall. So because of this reversal, when you actually have a smaller number as the numerator and a bigger number as the denominator, you're going to have a value less than 1. Okay. So when the EA is less than 0.8 and the E velocity is about less than 50 centimeter, because we know that the E wave has become shorter. Okay, that is grade 1. Similarly, the one number you want to know, the two numbers, at the end I will tell you the two numbers. Okay, so similarly, if the EA ratio is greater than 2, now that is straight away grade 3 diastolic dysfunction. Now again you can ask me, madam, how the EA ratio can be greater than 2? Because we established that in grade 3 diastolic dysfunction, the A wave becomes really short. The A wave becomes really short, that the E wave becomes taller. Okay. So again you have a bigger number being divided by a smaller number. So the ratio actually increases. So when the EA ratio is more than 2, it becomes grade 3 diastolic dysfunction. So this is very simple. Okay. In the presence of reduced left ventricular ejection fraction, the numbers you want to know first is what is the EA ratio. If the EA ratio is less than 0.8, then it is grade 1. If the EA ratio is more than 2, it is grade 3 with increased left atrial pressure. Now the confusion comes, what do you do between 0.8 to 2? Okay. Then again you go into the parameters that we took into consideration in the previous algorithm. The numbers are the same. Okay. The average E by E dash ratio more than 14, the TR velocity more than 2.8, and the left index left volume of the LA volume is 34 ml per meter square. If two of these criteria are present, then it is grade 2. If only one criteria is present, then you are not able to assess whether it is grade 2 or not. But if none is present and you still have this criteria, then it is grade 1. Okay, so these are the two algorithms that we will be applying to some of the cases in the subsequent slides. Now it is the same numbers, just put it in a tabular column for you to just have a visualization of those numbers again. So the numbers that I want you to remember is E by A ratio less than 0.8 and E by A ratio more than 2. More than 2 is grade 3 diastolic dysfunction and less than 0.8 is grade 1 diastolic dysfunction. Any value in between is grade 2 diastolic dysfunction, provided those three criteria are being met with. Now we have established that all the algorithms, we are just having all these numbers. So how do we obtain these numbers? How do we actually obtain these numbers? So we'll see them one by one. See, the first one is the mitral inflow. Okay, the pulse wave Doppler at the mitral inflow. So the view that you want to capture this image is the apical 4-chamber view. So that is step number 1, and you get a very good 2D image of the apical 4-chamber view. The second step is you put a color code so that you know where to align your sample volume, the flow of the blood. Okay. So the third step is you actually choose pulse wave Doppler in your echo machine, and you put the sample volume approximately 3 millimeters in between the mitral leaflets, and you press the pulse wave Doppler and take away. I mean, the aim should be to get a very sharp image, a very well delineated sharp image. Okay. So you press the pulse wave Doppler and you have this pattern, the mitral E wave and the mitral A wave. So how do you measure the E wave velocity? The peak of this wave you press there, and I'm sure those who are familiar with the machine knows where to choose them and how to measure and all those things. So the E wave and the A wave, as mentioned earlier, we used to measure the DCT as well as the A wave duration, but in the current algorithm there's not much emphasis placed on the DCT and the A wave duration. Now there are some limitations of this method. The limitation number 1 is when the heart rate is too fast, when the heart is beating at a rate of more than 100, naturally the E wave and the A wave tends to merge together, and we are not able to identify which one is the E wave and which one is the A wave. We'll be having certain, every individual have their own in the echo lab, every individual have their own way of finding a way to, slow down the heart and, capturing a good or leaving the thing for a longer cycle and capturing that particular beat where you're able to see the E and A wave and all those things. I wouldn't go into the detail of that because it is beyond the scope of this talk. But you need to be aware that one of the limitation of this mitral inflow assessment is one is tachycardia, where the A wave can be merged with the E wave, and delineating it can be difficult. Other one is the presence of atrial fibrillation or atrial flutter. We already discussed that in the presence of atrial fibrillation and atrial flutter, we don't see an A wave because the atrial contraction is not effective. Okay, and also when the patient has got mitral valve replaced, there will be aliasing. So this method cannot be applied on conditions like atrial fibrillation, atrial flutter, when the patient is having mitral stenosis or other mitral valve replaced, and those conditions. Now the next thing is the tissue wave Doppler. Okay. So how do we do a tissue wave Doppler? Again, the same thing. The view that you want for a tissue wave Doppler, TDI, tissue Doppler imaging, is 4-chamber view again. And then what happens is when you actually choose your 4-chamber view, you want to reduce the width and increase the frame rate. This is the most important step you have to do, because the TDI images are more sharp and more delineated when the frame rate is more than 100. So your ideal frame rate should be anything between above 100. Okay, so the way how you can do it is reduce the width of the image, and then then the frame rate increases. Okay. Then what you do is you press the PW button in your machine. So the moment you press the PW machine button in the machine, another option called TDI will lighten up. Okay. So you actually place your sample volume 5 to 10 millimeter at the mitral septum. See, this is septum. I'm sorry, I have actually narrowed it down, but this is the septum actually. Okay. So place it on the septum 5 to 10 millimeter just below the mitral annulus. Okay. It is very important. The other point in the Doppler TDI assessment is, the line should be parallel. Okay, so it should move perpendicular up and down with the septum. Okay, if there is any angulation, then there will be an error in the estimation of the velocities. Okay. So that is how we do the TDI imaging. So 4-chamber view, and then you actually reduce the width and increase your frame rate, and then you choose the pulse wave Doppler. You put your sample 5 to 10 millimeter in the septum near the mitral annulus, and you press your TDI, and then you will be getting the waves. Okay, the pattern. Okay. So here we have 3 waves, namely the S, the E, and the A. And for uniform nomenclature, these are named as S dash, E dash, and A dash. They are the same, whatever we saw in the mitral flow, it is the same thing happening here. Okay. What is the S dash denotes? The S dash is a surrogate of the LV systolic function. It tells you how effective your LV longitudinal fibers are contracting, because that particular tissue is moving up and down. Okay. And this is the mitral, similar to the mitral E wave that we saw, and this is similar to the mitral A wave that we saw. And in normal individuals, like how we saw the mitral inflow pattern, the E wave is taller than the A wave. And we also have 2 times that we can be timed here, the isovolumetric contraction time and the isovolumetric relaxation time. So the time interval just before the onset of the systole is the isovolumetric contraction time, and the time interval just before the onset of the diastole is the isovolumetric relaxation time. Now, the reason why I wanted to show this image is, not on all occasions you actually get an image like this. Particularly, we established that when there is a grade 2 or grade 3 diastolic dysfunction, the waves become smaller. That is in the mitral inflow. What happens in the tissue velocity, in the tissue Doppler, is not only the A wave becomes smaller, but the E wave also becomes smaller. The reason why the E wave becomes smaller is the LV contraction is not very effective. Okay, because what does the tissue, the mitral annular tissue is not very effective. Okay, so what happens is, identifying which one is the E wave, which one is the A wave becomes very, very difficult. I'm sure some of the experienced echocardiographer who are watching this webinar must have had this problem, particularly in heart failure patients when they're having tachycardia and you put this, they'll be having very small E wave, very small A wave, and when it happens so quickly, you won't be able to identify which one is the S wave, which one is the E wave and A wave, and there will be a lot of interferences. So the way how you go about it is, always take an ECG gated. Okay, ECG gated images. The reason why is, if you're in the confusion of identifying the waves, you can actually time it with the ECG. Okay, you can actually time it with the ECG, and then you can identify, okay, here comes the E wave and here comes the A wave. Similarly, you actually increase the speed. Okay, when you increase it, the tachycardia narrows down, and you actually your image becomes a little bit broader, and you have more clarity about these images. Then actually identifying the waves becomes easier, and measuring them also becomes easier. That is the reason why I have actually shown you this image, and this is a very common pattern we will be seeing in grade 3 and grade 2 diastolic dysfunction. And I'm sure you all know about the normal values. We already said that any septal E dash more than 8 is normal. Any lateral E dash more than 12 is normal. Any lateral E dash less than 10 is abnormal. Any septal E dash less than 8 is abnormal. I'm not going to talk about the S dash because this is a predominantly diastolic dysfunction talk. So let's not confuse about the S dash. But I did mention that the S dash is a surrogate for LV systolic function. So the third parameter that we saw in the algorithm was the LA volume. Okay. So again, the images that you want to measure the LA volume is, you want a apical 4-chamber view and you want an apical 2-chamber view. Okay. Now again, it is better, or it is mandatory that you do take it with an ECG gated images, because what we are going to measure is the end diastolic volume of in 4-chamber, end systolic volume of LA, and then in 2-chamber again end diastolic volume and end systolic volume. So actually the ECG helps, but having said that, you actually have to have a very dedicated LA view. Okay, so you have to concentrate on this LA view, and you have to ensure that there is no foreshortening of the LA. You have to make sure that the LA is seen at the maximum dimension. You know, the length and breadth of the LA is the maximum, and there is no foreshortening. Okay, that is more important. And again, also when in timing, ensure that you are actually capturing the really the end of the diastole and really the end of the systole by actually seeing which one is by actually manually seeing the volume of the LA rather than getting guided by the ECG. Okay. So once you've chosen your frame, when you are actually including the area, make sure that you don't include the pulmonary veins, the LA appendage, and the place just below the mitral leaflets. Okay. So you should not include the pulmonary vein area, you should not include the LA appendage area, and you should not include the space below the mitral valve. These are the tips that you should follow when you are measuring for LA volume. The most important tip is ensure make sure that you actually enter the height and weight of the subject into the system. Why this is important is, see, the LA volume or the LA dimension can vary from an individual to individual depending upon their height and weight. Okay. So once you index it to their body surface area, for that person, that is normal. For this person, this is normal. So to index it to their body surface area, you need to have the height and weight. So once you enter the height and weight into the machine automatically calculates your body surface area, and once you actually measure the LA volume, it will give you straight away the indexed measurements. Okay. And the fourth one is the measurement of the TR velocity. So again, for TR velocity, we can actually measure it either from the apical 4-chamber view or from the plaques view also. You want to have a Doppler jet which is actually without any angulation, and then you just want to put your continuous wave Doppler at the Doppler jet, and you want to have a very smooth wave, and you want to measure the peak velocity. So, but just to recap very quickly, we saw how to measure the mitral inflow Doppler, pulse wave Doppler at the mitral inflow, and we established what are the limitations of mitral inflow Doppler, and then we quickly went through how to measure the tissue Doppler imaging. And we actually discussed about the waveforms, and we actually established how to measure the LA volume and the do's and don'ts. And then we also established how do you measure the TR velocity. So whatever parameters is there in the algorithm, now we know how do we get all these values. Okay. With this, we will go to the interpretation. So when you have a patient, coming for an echocardiogram, and you want to make a comprehensive assessment about this patient, And one of the assessment that you want to do is how do you assess for the diastolic dysfunction? You want certain clinical details about these patients, which is very, very important. You see, sometimes what happens is in a busy schedule, we will be having patients whom we see our own, patients who have come to us for consultation. And we will also have patients referred to us by other clinicians just for echo. When we are really busy, it becomes a little bit, normal for us. We don't do it intentionally, but it becomes normal for us to just to go to the echo lab, do the echo and just come out. Okay. And then retrospectively, we don't know whether this patient has got hypertension, whether this patient has got diabetes, what are the other histories they have and all those things. So what I do in my echo lab is, regardless of whoever comes for the echo, in the echo lab, they should have a protocol where you actually tick the boxes. The boxes that you need to tick is, what is the height of this patient? What is the weight of this patient? What is the heart rate and the blood pressure? Is the patient having any thyroid problem? Does the patient have any lung problem? Does the patient suffer with hypertension, diabetes? Is there any previous coronary artery disease, any angiogram, angioplasty, CABG they have undergone? And is there any chronic kidney disease? Okay. Now, why have I included COAD here is for an important point. That is, see, pulmonary hypertension, presence of pulmonary hypertension, they have given so much of importance as one of the parameters for assessment of diastolic dysfunction, but only in the absence of lung disease. If the pulmonary hypertension is a part of the COPD or any right heart problem, then you can't take that into consideration when you are assessing for diastolic dysfunction. That is why it is important for you to establish whether the patient is suffering with any COPD, asthma or any other pulmonary problem that might be contributing to the pulmonary hypertension. Now, the first, as I mentioned earlier, in your algorithm itself, what we wanted to know is, am I dealing a patient with normal ejection fraction or am I dealing a patient with abnormal ejection fraction? Am I dealing a patient with normal LV dimension or am I dealing a patient with abnormal LV dimension? Is there any mitral valve pathology? Is there any aortic valve pathology? Is there any other condition in this heart? Okay. So a 2D image, a good 2D image is going to tell you about the ejection fraction, left ventricular hypertrophy, the opening of the mitral valve, the tricuspid, aortic, and any other, the right heart problem and all those things. So a proper assessment of the 2D image is very, very important for the diastolic assessment. Okay. Is there any presence of regional wall motion abnormality? Those things we can assess. So if you actually take this 2D apical 4-chamber view, it is a normal LV. The size and dimension of the LV is normal. The LV is contracting uniformly well. LA also, visually appears of normal size. Mitral valve is opening well. There is no, nothing in the 2D image to say it is a stenotic or a flail mitral leaflet or something like that. Okay, so a good 2D image is very, very important and it will help you to actually choose your algorithm. The second thing is, if you have the advantage of doing a strain, please do a strain, because we all know that the earliest finding in a diastolic dysfunction is an abnormal strain. Okay. And it gives you confidence, when you actually start doing this strain, it really gives you confidence in reporting. You have a normal strain and you're a bit of, not sure with your numbers, because we will see them in the later. Then it gives you confidence to actually make the decision whether this is abnormal or not. And similarly, when you have a grossly abnormal strain pattern like this, you know for sure that the patient is going to have diastolic dysfunction. Okay. Now, with this, we'll see some case series. Okay. So this is a young chap, about 24 years old male, who actually came for a routine chest pain assessment. Okay. So he doesn't have any other problem. His blood pressure is normal, heart rate is normal. He doesn't suffer with any chronic conditions that we discussed earlier, like diabetes or hypertension or CKD or anything like that. And as I mentioned earlier, the 2D image is normal. The LV is contracting well. There is no regional wall motion abnormality, and the LA size is normal, mitral valve opening well, and we are happy with this LV. Okay, so we are going to choose the algorithm that says that how to determine diastolic dysfunction in someone whose LV function is normal. Okay. So the 4 parameters that we need now is the average mitral E by E dash septal value, the TR velocity, the LA indexed LA volume, and the septal E dash and lateral E dash. Okay. So now we have those numbers. So we have the mitral inflow, the pulse wave optical inflow, the E and the A, and we have the LA volume, and we have the E dash and the A dash, and his numbers are, this is the very mild pulmonary hypertension that he has. The TR velocity is 1.70. Okay. So his numbers are this. So I'll just go through this again, once again. So if you see the wave pattern itself, okay, the mitral inflow wave pattern itself, you know that the A wave is taller than the E wave. Okay. And we established the 2D image is normal, and the LA volume we have measured, the LA size is normal. And again, when you come to the tissue Doppler imaging, the E wave is taller than the A wave, and the S wave is also reasonably sized. Okay. And as mentioned earlier, there is a very, very mild, I wouldn't call it as mild TR, it is a very trivial TR. The TR velocity is about 1.70 meter per second with a gradient of 11.5 millimeters of mercury. Okay. This is just for demonstration purpose. I actually measured his pulmonary vein Doppler. Okay, for people who haven't seen a pulmonary wave Doppler image before, what we do is, again, we actually focus on the pulmonary vein here. We put the sample volume actually deep inside the pulmonary vein actually, and then we get the Doppler pattern. So that we have the S wave, the D wave, and the A wave, and the A wave duration. These are the 4 parameters that we measure in a pulmonary wave Doppler. I just did it for demonstration purpose. So his numbers are, now, the average E by E dash is 4.5. The septal E dash and lateral E dash are 13 and 21 respectively. The TR velocity is 1.70 and the index LA volume is 8.51. So obviously these numbers do not match to any of our abnormal values. The abnormal values are more than 14 here, 7 and 10 here, 2.8 here, and 34 here. So this is a very much normal person who has a normal LV ejection fraction and a normal diastolic pattern. Okay, he does not have any diastolic dysfunction. So what you can do is actually in your echo format, you can actually, put these 4 parameters, and for reference, you can actually put abnormal values here as well. So it becomes a routine for you to put your value, interpret the data, and then say whether there is presence or absence of diastolic dysfunction. So this is case number 2. She is a 65-year-old lady. She's quite a tall lady, really tall. And she suffers from hypertension, she suffers from blood pressure, diabetes, she has hypothyroidism, she has a very mild episodic wheeze, she's postmenopausal, she has thyroid for which she is on L-proxin, she has osteoarthritis, and she has a APD. She came for the routine follow-up, and because of her diabetic status, we performed a routine echo, also because of a very remote history of chest pain. So now from the 2D image, again, you can see that the LV is contracting well. There is no abnormality. There is no regional wall motion abnormality. Eye wall assessment, LV ejection fraction is normal. LA wall size is normal. The mitral valve is opening well, and all segment of the LV is contracting well. Okay. Now, actually going to the images, the first thing is the pulsed wave Doppler at the mitral inflow, where the pattern actually shows a grade 1 diastolic dysfunction. This is what we have been routinely used to. Okay, there are still some of us who actually, as soon as we see this pattern, we say this is grade 1 diastolic dysfunction. So why we say that is because the E wave is smaller and the A wave is taller. Okay, so here the E wave velocity is 0.58 and the A wave velocity is 0.81, and the E by A ratio is actually 0.71. So it is actually less than 0.8. Similarly, if you take the tissue TDI imaging at the septum, the E wave is shorter and the A wave is taller. Again, looking at this, you might think that she'll be having a grade 1 diastolic dysfunction. The septum, similarly, the TDI imaging at the lateral wall and the indexed LA volume. Now, the point I would like to stress here is, this is a lady who has all the comorbid conditions, but her LVEF is normal and she doesn't have any left ventricular hypertrophy. She has a kind of what we are being used to the earlier grade 1 diastolic dysfunction pattern in the mitral inflow. But according to the algorithm, we have to go and see what her numbers are. Okay. So now this is her number. The average E by E dash is 8.3. So it is still less than 14. The septal E by lateral E dash is 7 and 8. So these two are actually less, because when the septal E dash is less than 8 and the lateral E dash is less than 10, it is abnormal. She is not having any TR velocity. Our indexed LA volume is 21, which is less than 34. Okay. So if you go along the criteria of these four, at least 3 or 4 should be positive for a diastolic dysfunction. She's only meeting one criteria, which is the septal E dash and the lateral E dash is abnormal. The remaining 3 criteria are normal. So because her LVEF is normal, this lady does not have diastolic dysfunction. Now again, this causes a confusion because the mitral EA is less than 0.07, but the mitral E is not less than 0.5. It is kind of 0.6. So even if you want to put into the other algorithm where the mitral E by A is less than 0.8 and the E is less than, she is not fitting into the criteria. So the reason why I thought this was very interesting is, some of us, including myself, I used to do it earlier, the moment we see this pattern, where the E wave is shorter and the A wave is taller, and with this set of profile where she is very, obese and tall and hypertensive, diabetes, postmenopausal, thyroid, everything, we easily brand her as a diastolic dysfunction. So we say grade 1 diastolic dysfunction and we produce the report. But the implications this has for the patient, they take the report to another clinician and say, what does this mean? What does this diastolic dysfunction mean to be? But otherwise, I'm telling you, this lady is a very active lady. She does all the household chores herself. She does not complain of any breathlessness. She's the main carer of her husband and she's happy. She's a happy lady. So that is why this algorithm and applying the numbers actually helps us in making a very precise, accurate diagnosis of the diastolic dysfunction. So now that this lady is not having any diastolic dysfunction, there is no need for us to even grade this lady. Okay. Now this is another gentleman who came to me for chest pain assessment. He is quite an obese guy, okay, really obese. His BSA was about 2.16. Again, he suffers with high blood pressure and diabetes. He has some COPD for which he is on regular inhalers, and he also has abnormal lipid profile. Okay. So I didn't find anything abnormal in the 2D image. Because of his obesity, the 2D image wasn't a great image, but still, the LV dimensions are normal. There is no regional wall motion abnormality. The LV function EF is normal and the LA size is normal. There is no mitral valve pathology and we are happy. So here again, the point I would establish is we are going to do a diastolic assessment on an individual whose EF is normal and he is not having left ventricular hypertrophy. Okay. Now, actually going into the mitral inflow pattern, you can see that the E and the A are of equal length. So earlier, if you had taken a little bit more time, probably this would have come shorter and taller, or this can be also fitting into the earlier criteria of pseudo, grade 2, where they say this is pseudo and actually you do the Valsalva maneuver and then you identify. So this is the pitfall here. But when you go to the TDI imaging, clearly the E wave is smaller, the A wave E dash is smaller, the A dash is taller, and the lateral E dash also smaller and the lateral A dash also taller, and we have measured the LA volume. So his numbers are, the average E by E dash is 18.25, which is more than 14. Okay. Now people say the one criteria you want to say for diastolic dysfunction is in a normal individual, in somebody who is normal, the average E by E dash is never more than 14. So if your average E by E dash is more than 14, it means that it is abnormal. The septal E dash and lateral E dash also is well less than the normal, less than 8 and less than 10. Okay. Surprisingly, he didn't have any TR. The indexed LA volume was normal. Okay. Now, in this 4 criteria, he is meeting 2 criteria. He is not meeting the other 2 criteria. So now we said that for somebody with a normal EF to say that they have diastolic dysfunction, they have to have at least 3 to 4 criteria. Okay, so this gentleman is only having 2 criteria. The mitral EA velocity is 0.9, so it is not less than 0.8. The mitral E is 0.9, so it is not actually less than 0.5, and the DCT is more than 236. Now, what do you do with this gentleman? Are you going to say that he does not have diastolic dysfunction, or are you going to do something else? Because he is a gentleman who complains of exertional breathlessness. He has come for chest pain assessment. And when you have a patient who is symptomatic, okay, it is either going to be coronary artery disease or it is either going to be diastolic dysfunction. So we can't just leave this gentleman just like that and say, hey, he is not filling 3 to 4 of the criteria, and I'm not bothered about these two numbers, and I'm just going to say that he's not having diastolic dysfunction. I don't think that is appropriate. What we do for this gentleman, we will discuss in the later slides. Now, this is a young chap, unfortunately, who suffered an extensive anterior MI recently and had an intervention, and he has been under treatment for heart failure management. As you see, actually, this LV is not very happy there. It is dilated. The septum is bright and akinetic, hardly any contraction there. EF observed will be at least somewhere between 30 to 20, 28 to 30, and the LA appears dilated. So now we know that we are actually dealing with a patient whose EF is depressed, reduced ejection fraction. So in the algorithm, you have to go and directly choose the algorithm which says EF, the assessment of diastolic dysfunction with reduced EF. Okay. So the first step in that algorithm is establish the EA ratio. Okay. So look at this gentleman's mitral inflow. You have a very tall E wave and a very short A wave because the left ventricular end diastolic pressure is elevated. The atrial contraction is not effective against this pressure. So the E wave is very short, the A wave is very tall, and obviously his EA ratio is going to be more than 2. So the moment you have this EA ratio more than 2, he goes directly into grade 3 diastolic dysfunction. The remaining all values is only going to help you to, kind of say his prognosis and yes, his E dash is smaller, A dash is smaller, and all those things. But this one picture in the presence of atrial reduced ejection fraction is going to tell you that he is straight away grade 3 diastolic dysfunction. So obviously he has a significant TR. The TR velocity is more than 2.8. It is about 3.31 with the gradient of 43 millimeters of mercury, and his indexed LA volume is also high. It's about 40.82 ml per meter square. So obviously his EA ratio is 4.42, which is more than 2. So here itself, we have established that he is grade 3 diastolic dysfunction. So that is how simple the algorithm is guiding us. So once you have a reduced EF, the one number you want to see is EA ratio. If the EA ratio is less than 0.8, grade 1. If it is more than 2, grade 3. In between 0.8 to 2, you actually take the other things into consideration and see whether it is grade 2 or grade 1 or none. Okay. But we do have these figures, quite abnormal figures, which we cannot ignore. The mitral DCT is only 12.6. We saw a number less than 160, but just see the DCT, only 12.6. The mitral E by E average is 27. Again, the number here is more than 14. Anything more than 14, anything more than 15 to be precise is very, very, critical, very critical. The septal E dash is 3 and LA volume and all those things. See, my dear friends and colleagues, if at all I want you all to take one information from this talk, know the E by E dash average of your patient. Write it down and know it. Okay, like your HbA1c. All diabetologists, you actually go along with the HbA1c, and it gives the overall control. It gives us an idea about how well the diabetes is under control. This value is that important. If you have a patient with LV systolic dysfunction and his E by E dash average is less than 14, he's going to be your patient for long. If you have a patient with LV systolic dysfunction and if his E by E dash average is more than 14, unfortunately, his numbers, his days are numbered. So try to be very aggressive with them, whatever you believe in, whether you believe in empagliflozin for his diabetic management, you believe in sacubitril valsartan for heart failure management, or you believe in spironolactone for heart failure, whatever you believe in, try to give him the best of the prognostically beneficial, prognostically proven medication, because this chap is going to not do well, unfortunately. And this number, make sure that you know the E by E dash average number of your heart failure patient. This is going to be your whatever mantra for your patients. So here itself we have established that he is grade 3 diastolic dysfunction, and all the other parameters is only supporting this argument. So this is another lady, again a 40-year-old female, DCM. She came to me a very late stage for breathlessness. This is the first time she's having an echo done. As you can see, all the 4 chamber is dilated, the LA is dilated, the LV is dilated, LV hardly contracting, all the segments of the LV is poorly contracting, the EF will be somewhere between 18 to 20. So surely she'll be having a jet of MR and TR. So again, once again, the algorithm that you have to choose here is assessment of diastolic dysfunction in someone with depressed EF, and the one number you want to know is what is the E by A ratio, and the other number you want to know is what is the mitral E by E dash average. And there you go, again we see the same pattern, the E wave is taller, the A wave is shorter, and obviously the E by A ratio here is going to be more than 2. Look at this, you can hardly identify where the A wave is, where the E wave is. As I told you, if you have a problem with this, make sure that your images are ECG gated. You increase the speed of this image, bring the waves more prominent, and then measuring it will be more useful, okay? And we have measured the LA volume, and of course she's had significant TR, and I also measured the pulmonary vein test out of interest. Now her numbers are the E and A 2.35, which is clearly greater than 2. So she straight away got the grade 3 diastolic dysfunction. And look at the E by E dash average, 43.4, far high compared to 14. So those two numbers I just want you all to remember. I mean, the TR velocity and the septal E bilateral and LA volume. LA volume nowadays gaining more importance, but I think the two numbers that I'm going to remember is the mitral E by E dash average and the E by A ratio. Okay, so clearly this lady has got grade 3 diastolic dysfunction. Again, this number is not telling us any good news about her, and we have to be really aggressive in her heart failure and diabetic management. Now, unfortunately, this video is not moving, but this is a chap again who is a 43-year-old male who presented to me with exertional breathlessness. And he doesn't have any diabetes, hypertension, thyroid or COPD or anything like that, and claims himself to be a very fit and normal gentleman. But for the last 15 or 10 days, he's been having this exertional breathlessness with bilateral leg swelling. And what we found was a hugely hypertrophied LV, HCM with no LVOT gradient and hugely dilated LA. Now, again, the algorithm that you want to choose here is the assessment of diastolic dysfunction in someone with a depressed EF or left ventricular hypertrophy. Again, your two numbers, the important two numbers is going to be the EA ratio and what is the mitral E by E dash average. Okay, so obviously, again, the same pattern we are seeing, the E wave is taller, the A wave is shorter. Clearly, the ratio is going to be more than 2, and we are seeing very small E waves and small A waves. And, hardly you can see the E wave and the A wave. And we also measured the index LA volume. And he's also got significant tricuspid regurgitation, TR velocity more than 2.8, 3.4 meter per second with a 46, a gradient of about 46, 47. Just measured the pulmonary vein Doppler out of interest, and his numbers are the EA is 3.1, clearly more than 2, and the E by E dash average is 21.99. So that's not sounding good. Okay. So clearly he has grade 3 diastolic dysfunction and his prognosis is poor. His LA volume is more, his septal E dash and lateral E dash also less than the criteria, and his TR velocity more than the criteria. Now this lady, I just put this slide because obviously in the 2D image you can see that 1, she's having atrial fibrillation, 2, she's having mitral stenosis, LA volume is increased, LA is enlarged, and she also has another involvement of the aortic valve as well. Okay. So what happens is we already established that in mitral valve problem, and when you have atrial fibrillation, the mitral inflow is not the right way. The mitral inflow pattern is not the right way to assess your diastolic dysfunction. All these people are going to have dilated LA, so the LA index volume is not good enough. All these people are going to have tricuspid regurgitation, so the TR is not good enough. So we need other parameters to say that this patient is having the diastolic dysfunction or not. Okay. And those parameters are, we don't do it routinely, but actually it's not that difficult. One is the peak acceleration time of the mitral E velocity. Okay, so how do you measure it is actually in your In your drop down column, you will have something, when you actually go to measurement and you click the mitral, this parameter, the peak acceleration time of the mitral E velocity comes in there. So you just have to click that option and place your caliper here, okay? And then it actually measures you just have to drag it up and it gives you the value. So the value here is 24,100. Anything actually more than 1,900 is abnormal. Okay, so anything more than 1,900 is abnormal, and this patient value is, sorry, there's a mistake there, 24,100. So this is clearly abnormal. The other thing that you can measure is the isovolumetric relaxation time, IVRT. Okay, so we have actually measured here. I don't know whether you all are able to see it clearly, but I actually told you earlier itself, how do we measure the IVCT and IVRT? Okay. So the time before the onset of your E wave is the IVRT, that is the isovolumetric relaxation time. And the IVRT normally is anything less than 65 is abnormal, and this lady's IVRT is 31 millisecond. Okay. And the other thing is the septal E by E dash average. This we can calculate because we have the two things. Once you have the the mitral E velocity and you have the tissue Doppler E velocity, so you can always calculate the average. So by this, these two criteria, unfortunately, I couldn't measure for this lady, but with these three criteria, we know that this patient is having diastolic dysfunction. Now, I actually told a friend of mine that I'm going to give a talk about diastolic dysfunction, and he's an interventional cardiologist, and he mocked at me saying, "What are you going to do by knowing diastolic dysfunction?" So, see, first of all, when you actually assess the diastolic dysfunction and when you try to fit them into the guidelines recommended protocol, I think your reporting becomes more precise, your reporting becomes more sophisticated, and your reporting becomes more academic. So that gives a big confidence for yourself as well as from your colleagues that, this assessment is a very comprehensive assessment. I think that is very, very important. Number two is, as I mentioned earlier, please know the E by E dash average of your heart failure patient, of your MI patient, because that one value is going to tell you whether your patient is going to survive or the patient is going to die, whether the patient is going to develop diastolic dysfunction in the future or not, and whether your patient is going to have heart failure or not in the future. So anytime you have an MI patient or you have a routine patients with the DM or hypertension and you're doing a routine follow-up, get the number, document it, and ensure that your clinical choice of medications are guided according to the E by E dash value. It is that important. Now, finally, diastolic stress echocardiography. I'm not sure how many of you do it. I don't do it myself, but we discussed a case there, one 65-year-old gentleman who was very obese and who came for chest pain and breathlessness assessment. And, he didn't have four criteria, no? He didn't have three to four criteria, but we established that he is symptomatic and we cannot just ignore these two criteria, and we cannot say that he's not having diastolic dysfunction. This gentleman needs some further assessment. So we established that, and this is what he needs. That is, you actually make them, because his symptom is exertional breathlessness. So when you do an echocardiogram, when he is not exerting himself, his numbers are going to be less. So you exert him, you try to stress his heart, and then you do the diastolic assessment and find the values. So if you do the ASC, the ESC, and the Australian societies, they all put a very strong recommendation for this diastolic stress echocardiogram, but unfortunately it has not come into clinical utility just as yet. But hopefully in the future, this will be a modality that all of us will be using for our patients where we will have some difficulty in diagnosing with a diastolic dysfunction. So, my dear friends and colleagues and all my delegates who are watching this program, to conclude, the diastolic dysfunction determination is predominantly done by echo parameters. So what we want to know, the first step is categorizing your patient where they fit, whether you're doing a diastolic assessment in someone with normal EF or you're going to do a diastolic assessment in someone with abnormal EF or abnormal left ventricular hypertrophy or abnormal valvular heart problem. So once you actually do this, choose your algorithms, memorize the numbers, have it in your protocol, try to fit the numbers and see whether the patient has got diastolic dysfunction or not. Once they have got diastolic dysfunction, try to grade them. And once you know the number, the E by E dash, and if someone has got a higher number, aim your treatment according to the E by E dash average number. Thank you so much. I'll be very thank you all for your patience listening, and I'll be very happy to take any questions if there are any.
Yes, we do have a lot of questions, ma'am, and thank you so much. It was a really, you didn't have the crowd in front of you, otherwise you would have seen that how many questions are there. And
Okay.
they've been doing a lot of questions they are asking so that they can interact with you. With your permission, shall I go ahead, ma'am?
Sure, please do.
So, ma'am, I would like to start with the mitral propagation velocity, which is from Dr. Manak. He would like you to please touch base upon color M mode velocity propagation. Do you still recommend doing mitral propagation velocity, ma'am?
Sir, thank you so much for that question, and thank you for asking that question. Actually, it is one of my very favorite. I was doing it earlier. The steps, how we do it, you're familiar with the steps. I was doing it earlier, but there was no, I didn't find it was correlating clinically with whatever assessment I was doing. It was fun to do that, it was fun to do the assessment and get that beautiful images and measure the slope. But every time I did it, I was going wrong with my assessment. So luckily or thankfully, the guidelines has now taken it off, so I wouldn't be doing it anymore. However, if there are some gray areas, like, we had a gentleman where we had difficulty in diagnosing whether he has or not, or grading, or we will have other patients. So if it's going to give us some added information, then please do, but not in my routine practice.
Thank you for the explanation, ma'am. One of my mentor, Dr. Vidya Suratkal, has requested to touch base the criteria for stress test to be set positive for diastolic dysfunction, which you touch based. But if you can elaborate a little more on that.
Sir, actually, as I mentioned, when you have a difficulty in seeing, when your patient is symptomatic, when your patient is complaining of breathlessness or chest pain, and you know that your patient is having some problem, but your resting echo is not supporting, or it's not very clear cut in making a diagnosis or grading of diastolic dysfunction, then we would like to do the diastolic stress echocardiography. Obviously, we need to have a lab which can facilitate doing that. A pharmacological stress, stressing the heart using pharmacological agent is not recommended. So the other two things that is recommended is a treadmill testing or your supine bicycle thing. But again, the treadmill testing, we can't be making them walk and do the assessment and all those things. So the preferred one is the supine bicycle. So what they do is you do according to the, you have the table and you do it accordingly with the one step and second step. And in every step, you actually measure the whatever parameters that we discussed now, and see whether the patient actually, as the exercise increases, as the patient becomes more breathless, whether the parameters that was there and the resting and the exercise induced is different, and now he is developing any diastolic dysfunction. That is all it is, sir. It is very simple. I mean, as long as we have that lab facility, I think it is doable.
Right, ma'am. Ma'am, Dr. Ashok Sethi sir has asked, in the old age, most of them has a diastolic dysfunction. Do you still recommend to report it as a grade 1 diastolic dysfunction?
Sir, actually, very interestingly, when we apply the algorithm, okay, I think we all should come out of this routine practice of as soon as we see that inversal of mitral EA ratio, branding it as grade 1 diastolic dysfunction, I think we should come out of that routine regardless of anybody's age. And we have to go along with the protocol. So I assume that you are saying that your old age patient is having normal ejection fraction and normal LV dimension without any left ventricular hypertrophy. So in that manner, only if he fulfills the 4 criteria, that is, his LA volume is high, or he has got tricuspid regurgitation, or his E by E dash average is more than 14, then only he actually becomes diastolic dysfunction itself. But he has to have 3 out of 4 criteria. I showed you a classical case, a lady 65, her EF is normal, she has all the comorbid condition, hypertension, diabetes, COPD, hypothyroidism, everything, but she's not fitting into the 4 criteria at all. She's not, she had only 1 criteria. So I wouldn't call her as diastolic dysfunction. I think I will apply the algorithm only if 3 to 4 criteria are positive, then I will say it is diastolic dysfunction, and next step will be grading. I wouldn't be straight away branding them as diastolic dysfunction simply because of their age, particularly if their EF is normal and there is no left ventricular hypertrophy.
Right, ma'am. There is another interesting question, ma'am. How to optimize drugs in patients with atrial fibrillation with CVR and preserved EF? Any specific echo parameters to assess LV diastolic dysfunction? NT-proBNP is an expensive investigation to keep these patients asymptomatic.
Yes, sir has combined, biochemical, echocardiograph, symptom, everything into one question. Sir, actually, in atrial fibrillation, I showed you a case where there is a mitral stenosis and there is atrial fibrillation. Again, we don't go along with the routine parameters like your EA ratio or your septal, those parameters, or your pulmonary hypertension in establishing diastolic dysfunction, because all these are going to be abnormal anyway. Having said that, even if you actually apply the most specific criteria, it is going to be positive because they are going to have diastolic dysfunction. That is for sure. Okay. So how do we optimize when it becomes, how do we optimize the treatment? Okay. Utilizing the pro-BNP as a tool for optimizing treatment, I don't think we do it in the routine clinical practice. Maybe when a patient presents with breathlessness and if we think whether it is a cardiac or pulmonary, at that juncture we might be doing, but for routine follow-up, I don't think we do the BNP. That is number 1. Number 2 is echo-wise, you can actually, I don't think, again, the echo is going to decide optimization of your treatment. But as I told you earlier, the E by E dash value, that can be obtained even if the patient is having atrial fibrillation, because you will have a mitral inflow pattern, you can measure the mitral E wave. With your tissue Doppler imaging, you can measure the mitral E septum. So that number you can get. So what I would say is atrial fibrillation, look at the underlying cause, treat all the risk factors, control his diabetes, control hypertension, weight reduction, thyroid, everything. And the rate control is very important. Here you have to decide what strategy you're going to choose, whether you're going to take a rate control strategy or whether you're going to go for a rhythm control strategy. Because in atrial fibrillation, a rhythm control strategy is always more efficient and more, recommended than a rate control strategy. So try and get them back into normal sinus rhythm if possible. That can be done either by electrical cardioversion or by pharmacological cardioversion. So once your rhythm is controlled, then your problem is sorted. But for some reason he is permanent AF, or you've got to accept your AF, then what is more important is the rate control. Okay. So then it just narrows down to what is the rate of the patient as assessed by your ECG, as assessed by his symptoms, and what are the rate controlling tablets you want to choose. Obviously, if he's having heart failure, you're going to give him a beta blocker. If he's got a COPD or anything that prevents him taking beta blocker, you're going to give dilzium. So that depends upon the underlying condition of the patient. But I don't think echo parameter and BNP actually helps the person's AF, treatment of AF.
Right, ma'am. Dr. Shahidul has asked, what are the clinical implications for diastolic dysfunction in pediatric age group?
That's a bit difficult question, sir. I do pediatric echoes, but that's largely confined to for determination of congenital heart disease. When I was preparing this talk, I went through a paper about the tissue Doppler imaging in neonatal. Sir, please leave your number with Ashish. I will definitely go through some literature, discuss with my pediatric cardiologist colleague, and I will definitely get back to you with the answer. Ashish, please take his number and can give it to me. Once the session is over, I will do some background working and answer sir's question. I'm not sure about this because we don't do, as adult cardiologists, we don't do that amount of diastolic assessment in pediatric cardiology.
Sure, ma'am. So I request you to kindly share your number.
Sure.
I think, ma'am, that grade 1 is diastolic dysfunction is overdiagnosed. This is from Dr. Sanjeevni Inamda, ma'am.
Mm-hmm. So say that question again. Sorry.
Grade 1 diastolic dysfunction is overdiagnosed, as you said.
Yeah. Yes. I think it is overly diagnosed, particularly in people with reduced, normal ejection fraction. Because people with reduced ejection fraction or left ventricular hypertrophy, they will be having a number of some degree of diastolic dysfunction. Okay. It's very, very rare to see people with reduced ejection fraction or left ventricular hypertrophy not having diastolic dysfunction. But in normal individuals, I think we as a clinician, the moment we see that the inverse DEA pattern in the mitral inflow, automatically we say it is diastolic dysfunction. I think hereafter we have to be a little bit more careful in branding somebody as diastolic dysfunction, particularly when the EF is normal and when their underlying heart does not have any other problem. I think that bit is overdiagnosed.
Right, ma'am. Another question from Dr. Sanjeevni. We have been talking about EF. So should we decide normality of heart action by GLS, global longitudinal strain, rather than EF, especially in left ventricular hypertrophy patients, because there the EF will be always highly estimated?
Yeah. Sir, actually, thank you so much. That is, a complicated question, but as I'm hearing the question, I'm thinking through. See, you made a very valuable point. Okay. EF actually, the global longitudinal strain and EF actually, they do and do not correlate. But by and large, when the EF is less, the global longitudinal strain is also less, but you can have a normal EF and an abnormal global longitudinal strain, as you mentioned. Not in left ventricular hypertrophy, this can happen in other problem also. Okay, without left ventricular hypertrophy also, if somebody is developing diastolic dysfunction, the earliest abnormality is an abnormal global longitudinal strain. But to answer to your question, see again, what I'm trying to say is with this particular point, okay, it doesn't matter because your algorithm is the same for reduced ejection fraction or left ventricular hypertrophy. Okay, so this person, either way, you're going to choose that algorithm only. Whether the patient is having reduced ejection fraction or the patient is having left ventricle, because I'll go back to this slide. I showed you a patient with left ventricular hypertrophy, and actually the GLS that I showed you belongs to this patient only. The grossly abnormal GLS that I showed you belongs to this patient only. This GLS actually belongs to that patient only, actually. Okay. And his EF was something like 50. Okay, his EF was something like 50. But when we report itself, we say that this EF is an overestimation because of the LVH. We don't accept that EF. We know for sure that that EF is wrong. So we give a caution to the clinician as although the EF is 50, don't get misguided by that. That EF is contributed by that LVH. So that is one aspect. Okay. But for diastolic dysfunction assessment, whether it is reduced EF or LVH, the algorithm is the same. So what you're worried is, what is this E by A ratio? So if the E by A ratio, as I showed you, is more than 2, then he has got diastolic dysfunction. And it's kind of the same even when you have a reduced ejection fraction. But I hope I've answered your question. But if you have any further clarification, you can shoot me again. I think I've answered your question. But if you ask me what would I go along with, I think I would go along with both with the EF as well as with the global longitudinal strain. But if assessing for diastolic dysfunction, I don't think it makes a difference because the algorithm is the same anyway.
Okay, so there is another, as a technology provider, I'm really proud that no doctors have started practicing strain, because our next question is also about strain only, ma'am. The second case that you have shown, ma'am, the lady is having diabetes, DM. So the systolic function is normal in her case. There must be some degree of diastolic dysfunction according to the guidelines. In this case, do you think it is important to do strain imaging?
Yeah, sir. In our echo lab, we actually do strain imaging for all the patients. For your kind information, we have done strain imaging for this patient also. I'm sorry if you have felt it appropriate, I would have shared the strain imaging. Her strain was less. Less in the sense, not grossly abnormal. It was about, I think, 15 or 16. It is not above 80. was mildly reduced, but definitely the strain imaging will help you in making your assessment more scientific, Yeah, if you have the luxury of doing a strain analysis, please do it with all the patients. And her strain was mildly reduced.
Right, ma'am. There is a compliment for you from Dr. Rakesh. He says that excellent presentation, Dr. Vatchsala.
Thank you so much, sir. Thank you so much, and thank you so much for watching. It is a great privilege for me that Dr. Rakesh Gupta, President of Indian Academy of Echocardiogram, New Delhi, is watching my program. It makes me feel happy. Thank you so much, sir. Thanks a lot.
Next question from Dr. Rumin. Volume index significance in points of hypertension.
Sorry, sir, say that again.
Volume index significance in patients of hypertension.
LA volume, indexed LA volume, is that the question?
Correct, ma'am.
Yeah. So you're asking me whether it is significant in patients with hypertension. LA volume, indexed LA volume, is it significant in patients with hypertension? Is that the question?
Correct, ma'am.
Yeah, I think it is significant. See, because the moment you start doing this particular assessment routinely, okay, then only you will realize that in a 2D image, we make a visual assessment and we say this LA is dilated, this is the patient has got left ventricular hypertrophy, and we with the overconfidence we say LVH with dilated LA, okay. But LVH dilated LA is not equal to increased indexed LA volume, okay. So if you measure, because see this gentleman, patient 3, this gentleman, when you look into the 2D image, he's got hypertension, he's quite obese, and when you look into the 2D image, I think the LA here appears dilated, okay. But actually his measured LA indexed volume was only 20, so it is less than 34. So the more and more we start, there's even a saying which says the more you know, you realize how less you know. So the more and more we start analyzing, using these modalities and finding the precise information, then I think we will realize that assuming something is not correct. So we need to have objective evidence. So I think your question is, all patients with hypertension will have left ventricular hypertrophy, their LA will look dilated. So is it relevant? I think yes, it is relevant, and yes, it is important to establish that the LA indexed volume is actually high. And Sir Rakesh Gupta sir is a big fan of LA volume. In all the exams, there will be a question about LA indexed volume. So at least for that, I think you should measure it and know the value.
Right, ma'am. So there is a question that how to measure E by E prime.
How to measure E by E? See, actually, E by E prime is not something that we measure. I mean, we do measure, but the machine automatically calculates it for you. Okay. So the first step is actually getting your E value. So the first step is getting your E value. So for that, you need to have a pulsed wave Doppler put at the mitral inflow. Okay. So the view you want to take is an apical 4-chamber view. So get a proper apical 4-chamber view. The second step is put a color coding. And once the color coding is there, align your sample volume parallel to the color coding and put the sample volume 3 millimeter in between your anterior and your mitral leaflet. Okay. And press your pulse wave. Once you do that, you get this image. Okay. So with this image, you can get your E value and your A value. So the peak of this wave is the E value and the peak of this wave is the A value. Okay. So this will be stored. You store this image, it will be stored in the machine. Okay. So the next step is you go and do a TDI image. Okay. So again, for the TDI, you need to have an apical 4-chamber view. But the second step I told you is try to reduce the width and increase the frame rate, because you want to just concentrate on this bit, the septum. Okay. So as I have shown here, okay, and you put your sample volume 5 to 10 millimeter just at the area of the mitral annulus in the septum, and you press the pulse wave. Once you press the pulse wave, a TDI icon in your machine will automatically brighten up, okay? And you have to press, the second step is press the TDI, okay? Once you do that, you will get a wave pattern like this. So in this wave pattern, then you can measure which one is the S wave, which one is the E dash, S dash, E dash and A dash. The moment you measure the E dash and the A dash, the machine will automatically calculate you and tell you the E by E prime, okay? And the next step is you have to repeat the same procedure and go and measure the same thing in your lateral. So only when you measure the lateral, you will get the E by E prime average. So what does the E by E prime average says is, it is the average of the E dash in the septum and the lateral and the ratio between that average and your E dash. So the machine automatically calculates it for you. Okay, all that you have to do is give the values to the machine. Okay, it is very simple, very simple.
Right.
Sir, is it clear? Is it clear, Ashish?
Yes, ma'am, absolutely.
Okay,
and
sure.
Even if you want to see how it happens in Vivid, you can call any of our application team members.
Absolutely, yeah.
Then again, ma'am, another question with a compliment. Thanks, madam, for such a comprehensive talk. The case number 3, where other parameters are normal except E by E prime. We do get such cases often. Then how to go ahead in usual clinical practice? How about correlating with AFI?
Sir, actually, this person's AFI was abnormal. I mean, to take it further, I made him walk on the treadmill. That was very brave of me to make him walk on the treadmill. He walked about 4 or 5 minutes and he became very breathless. Now, unfortunately, with that treadmill, quickly, if we had actually done an echo assessment, I'm sure his diastolic dysfunction, we would have had other criteria fulfilled and he would have had a diastolic dysfunction for sure. Okay. But I think this gentleman more than, he's having diastolic dysfunction. Only thing is, he's not meeting the criteria because we did the echo on rest. But as I told you, he is an excellent candidate for diastolic assessment on stress. Okay. Second thing is, I think he will also need assessment for coronary artery disease. So some kind of invasive or non-invasive assessment we have to do for coronary artery disease. So those 2 things we have to do. So number 1 is a stress diastolic assessment. Number 2 is assessment for coronary artery disease. AFI will definitely help, reduce strain will definitely help. But I think these 2 are more important than AFI. And obviously you can also, do a AFI before the strain and after the strain before the stress and after the stress also. That also will help you.
Great, ma'am. Another question from Calcutta directly from Dr. Madhumita Bhomik. A patient is HCM non-obstructive. His E by E prime is 45.2. Is it correct, E by E prime?
Yeah. Yes. Why, madam? Why the doubt? Because I showed you a case that you have doubts here. This patient. About this patient, sir? Madam is asking about this patient, huh?
Correct, ma'am.
Yeah. Madam, here, as you see, the E velocity that we have measured is 1.04. Okay, so the E wave is quite tall. And the E dash is 0.03. 0.03 is the E dash. So then just see the ratio. I think that is correct, but at least that is what the machine has given us.
So I accept it as correct. Dr. Manik has asked another question, and I'm keeping the last toughest question for the last question, but this is second last question which Dr. Manik Mukhopadhyay sir has asked. When do you evaluate the RV diastolic function? Do you do it routinely or only in case-to-case basis?
RV diastolic function.
Correct, ma'am.
I don't do it on a routine basis, sir. Sorry, unfortunately, I don't do it. RV systolic function we measure routinely with the TAPSE and systolic S dash and other parameters, but RV diastolic function, I don't do it, sir.
So, last question, ma'am. This is again from Dr. Vidya Suratkal, ma'am. So, she has emphasized on one thing. So the first thing which he mentioned is, please discuss criteria for a stress test to be said to be positive for diastolic dysfunction. Criteria to say positive.
Criteria to say stress test is positive for diastolic dysfunction.
Correct, ma'am. So I'll read it once again, ma'am. Please discuss criteria for stress test to be said to be positive for diastolic dysfunction. Criteria to say positive.
Madam, actually, I went through the literature. I don't think there's a specific criteria. What my understanding is, or like I showed you a case where we are having gray areas that they are not filling into the 4 parameters. And when you actually apply the stress, and when upon stress, if your E by E prime is more than 14, or LA volume is more, or the patient develops TR, or all those 4 criteria meets, and 3 or 4 out of that is positive, I think it becomes positive. That is my understanding. Correct me if I'm wrong.
Sure, ma'am. We will try to take the feedback from ma'am and our other participants. And if there is any question, we will try to get in touch with you and connect you with them. And it's just 1.5 hours, ma'am, but it was really a nice session. We really enjoyed it. And I really want to thank you for the informative session. It was having a great reception from our audience. I'm sure the clinical cases are going to help our viewers in their practice, and they can do diastolic dysfunction and accurately tell that when it has to be considered and not to be considered, to not be having any confusion again. Thank you once again. A big thank you to all our viewers for your continued support. Stay tuned for our next webinar session, which will be announced soon. Thank you so much, ma'am.
Thank you, Ashish. Thank you so much. Please do give me the number of the pediatrician who asked about the neonatal, pediatric diastolic dysfunction assessment, and also ma'am's number also, about the set criteria for diastolic assessment. I'll go through the literature and see if we have to add anything more.
Sure, ma'am. I'll do that.
Thank you, Ashish. Thank you, Ashish. Thank you. Thank you all. Thank you all for your wonderful participation, for making this session more interactive, and for all your lovely questions. I really enjoyed answering them, and thank you so much for listening.